The word was coined from the Greek word leukos and hema, and it actually means, leukos means white and hema means blood. So what is leukemia? Hello friends, today we will be talking about a very important topic in your undergraduate studies as well as in your future, where you could be dealing with a lot of patients who may be presenting to you with varying presentations, and unless you know about the presentation, you may not be able to identify. So today's topic for discussion will be leukemia. I'll be taking you through a few case scenarios, but the details of the case scenario, how this particular patient was dealt with and all, we'll deal with it at the end of the presentation, because initially we'll just go through the case scenarios, understand how the patient presented, and then understand about the basics of the diagnosis, the types of leukemia, the epidemiology, the predisposing conditions, the pathophysiology, findings, confirmation of diagnosis, confirmation of cell of origin, how to screen for complications and how to treat it. And after that, once we come back to the case scenarios, you will be able to understand better that why the diagnosis of this particular condition was made in such a particular way. So shall we start? So coming to the first case scenario, we have a 35-year-old gentleman who presented to the general medicine OPD with complaints of gum bleeding of 2 days duration. On examination, this patient had active bleeding present from multiple sites on the gum. It's not in one single site. He also had subconjunctival hemorrhages. When you look at the patient, he looks very conscious and oriented, no organomegaly, and the vital parameters were stable. Normally, in such a situation, you probably would be thinking about thrombocytopenia alone. But when the patient's the blood counts were looked into, it is not only thrombocytopenia that you will be able to find out. This patient has a anemia, he has a leukopenia, and the differentials seem to be more or less maintained, and he has a thrombocytopenia. So he has all 3 cell lineages affected in this particular patient. So it is not only thrombocytopenia which is there in the patient, and he has a pancytopenia. Now, when you look into the peripheral smear, you have normocytic normochromic RBCs, which rules out most of the nutritional problems like B12 deficiency, folic acid deficiency, iron deficiency, and all. So it is not a nutritional deficiency. And this particular finding, which is 2 nucleated RBCs per 100 WBC. Nucleated RBC, finding nucleated RBC should, in the peripheral smear, should actually ring bells in us, because it is a very classical finding that the bone marrow is at stress. Only when the bone marrow is at stress, this nucleated RBC gets thrown out from the bone marrow into the peripheral blood. Normally, the nucleated RBC, which is the erythrocyte, which has not matured, remains within the bone marrow. So here, there is something wrong with the bone marrow. And you actually have 15% blasts, promyelocytes of 47%, neutrophils only 3%, and lymphocyte 31%, and you have a platelets of 45,000. So when you look further into the other coagulation parameters, you would actually be able to see that this patient has a prolonged prothrombin time. He also has a very prolonged activated PTT, partial thromboplastin time. And when you look at it, the fibrinogen is also low. So in this situation, actually when you have a patient who has a thrombocytopenia, or rather a pancytopenia with a prolonged PTINR, prolonged APTT and low fibrinogen, that should actually make us very alert that this patient he already has a DIC. So this patient could be a acute promyelocytic leukemia. So how do you find out that whether this patient has an acute promyelocytic leukemia? I'll take you through the slides. So when you look at the blast, you can see that the size of the blast is almost approximately 7 times the size of the RBC. Okay, so this is a huge blast when you compare with the size of the RBC. And when you look into the cytoplasm of the blast, you could actually see that the cytoplasm shows granules, and occasionally you can actually see the rods. See, okay. So here, this particular thing actually makes you understand that this patient could be having an acute promyelocytic leukemia. Okay. Coming to the next case scenario, we will be dealing with the treatment and all again once more at the end of the presentation. So coming to the second case scenario, now you have a 75-year-old gentleman who has come to you. He had done an annual checkup of his bloods, and his blood count is showing 65,000 WBC, and with only 3% of polymorphs and 97% of lymphocytes. So what could be the condition that this patient could be having? When you look into the other blood parameters, you can see that his HB is 14. His HB is 14, which means that it is almost normal. His platelets are also 2,77,000, which is also similar, almost normal. And he has already done a peripheral smear. The lab has already done a peripheral smear for them when they saw his high counts. And it shows occasional smudge cells, and the blood picture is showing predominant small lymphocytes. Platelets are adequate. RBC is normocytic monochromic. So on clinical examination, in such a scenario, when you already have somebody coming with you with high counts, with high lymphocyte counts, you should be particularly concentrating on what may be the clinical findings in this patient, whether he has a generalized lymphadenopathy or a significant lymphadenopathy, even if it is in only one area, that should also be considered significant. So, and whether he has a clinical hepatosplenomegaly. When you palpate the abdomen, if the spleen and liver are enlarged, firm in consistency, all these should be considered as red flags. But this patient did not have any clinical lymphadenopathy or hepatosplenomegaly. The smear showed these are the smudge cells. These are the smudge cells, and when you look at the lymphocytes, they are all similar to the size of the RBCs. They are small lymphocytes. This is how you saw this patient's smear. This patient probably could be having a chronic lymphocytic leukemia, and about the treatment, we will come to the scenario once more at the end of the presentation. Now, this is a third person who has come to you with a increasing fatigue with dry, persistent cough for the last 3 weeks. The history as the patient was completely normal 3 weeks back, and now he is having increasing fatigue and persistent dry cough. When you look at him, he is conscious oriented. He has had a weight loss of 3 kg noticed from the last measurement, and he doesn't know that whether it has happened over the last 3 weeks or was it present even before. When you examine him, you find that he has bilateral, significant, firm, cervical and axillary lymph nodes. His spleen is enlarged, and it is 4 centimeters below the left costal margin. He has bilateral chest, air entry is equal bilaterally, but he does not have any crepitations or bronchi heard. When you examine the cardiovascular system, there is no murmur, no this S1 and S2 normal. Now, this particular patient, because he has been complaining of persistent cough, an X-ray had been done. So, what do you see in the X-ray of this patient? So, normally this would be the area. This is how the mediastinal part should be. But in this particular patient, you actually see that the upper part of the mediastinum, it seems to be enlarged. when you look at the peripheral smear, what do you see? You can see that the patient has very cells which are blasts with very large nuclei, sparse cytoplasm. The cytoplasm doesn't seem to be having any granules like you saw in the first patient. But when you look at it, are you able to appreciate the small handle-like appearance here? Okay, so these blasts are actually called hand mirror blasts, and they are pathognomonic of clinically, when you look at the microscopically, they are pathognomonic of T cell leukemias, acute T cell leukemias. Coming to the fourth case scenario, now we have a 28-year-old football player. So previously he did not have any comorbidities, and he is complaining of increasing fatigue. He is not able to keep up with his peers while playing football, and also he is not able to eat like before. So what does this mean? So not able to eat like before is something which should actually alert us regarding this person could probably be having a splenomegaly. So why should somebody who has a splenomegaly not be able to eat like before? Because even though their appetite is normal, even though they have hunger, even small amounts of food when they try to have, as compared to earlier time, because of the spleen, the mechanical impingement of the spleen over the stomach from behind, the capacity of the stomach comes down. So what will happen? They will not be, with little amounts of food itself, they feel full. So they're not able to eat like before. That's what he was trying to tell us. So when this patient, he also has a weight loss because he is not able to eat. When you examine him, you notice that he has pallor. He doesn't have any lymphadenopathy, but he has a massive firm splenomegaly. Firm splenomegaly. And when you look at the CBC, you see that he has a very high WBC count. He has a very high WBC count of 1,20,000 with predominant neutrophils, and he also has basophils circulating in the blood. Both these, along with a massive splenomegaly and high counts, should actually be alerting us that could this patient be having a chronic myeloid leukemia. Okay, so when you look at the peripheral smear, that is it. So you have all types of myeloid cells, the myeloblast, the promyelocyte, the myelocyte, the pronormoblast, everything coming into the circulation. And you have the mature cells, the band cells, everything is there in the peripheral smear. So this is a case of chronic myeloid leukemia. We'll come to the treatment again at the end of the presentation. So what is leukemia? So leukemia is a heterogeneous group of neoplasms arising from abnormal and uncontrolled clonal proliferation of transformed hematopoietic progenitors following one or more somatic mutations, usually with a retained partial capacity of differentiation and characterized by diffuse infiltration of the bone marrow. I know that sounds a very, very, very difficult definition, but the key words in this particular definition, which we should not be missing when we are trying to express it, would be the abnormal and uncontrolled clonal proliferation of transformed hematopoietic progenitors. That part should be there, and it happens because of somatic mutations, and we need to understand that every leukemia there will be an infiltration of the bone marrow. So these are the things that have been combined together to form this definition. So from where do we get this? The word was coined from the Greek word leukos and hema, and it actually means, leukos means white and hema means blood. Okay, so coming to the types of leukemia. So broadly, the leukemia can be classified into lymphocytic and myelogenous. The lymphocytic leukemia could be acute lymphocytic leukemia or chronic lymphocytic leukemia, and the myelogenous leukemia could be acute myeloid leukemia or chronic myeloid leukemia. Again, the acute lymphocytic leukemia is subdivided based on the cell of origin to B cell, T cell, and mixed phenotype. Meaning, the blast could express both the B and T cell markers. By the FAB classification, the acute myeloid leukemia is classified into M0 from M0 to M7 based on the different morphology of each of the blasts. We'll go through a few slides so that you are able to identify regarding the types of blast. So initially, the first slide that you see is of acute lymphoblastic leukemia, and in this particular slide, you will be able to appreciate that hand mirror which I spoke to you about earlier in the previous patient. This is much more clear. You actually look the area which I have encircled actually shows the blast which has something like a handle to hold it. So this is very classical of a T cell acute lymphoblastic leukemia cell. And you've seen the smudge cells in the previous scenario. You have noticed all the different kinds of maturing forms of the myeloid series in the CML slide, and in the acute myeloid leukemia slide. These blasts are different from what you saw in the previous patient who had OR rods. But again, when you look at the size of the myeloid blast, it is bigger than the RBC. It is much bigger than the RBC. These are huge cells, and each cell is different from the others. Each cell has the morphology very different from the others. So, unlike acute lymphoblastic leukemia, where the cells look very similar to each other, they are called non-school uniform, like convent school uniform children, and the myeloid group are very heterogeneous. So coming to the epidemiology, in 2018, leukemia has been the 11th leading cause of cancer-related mortality all over the world. And in 2020, 3.4% of all new cancers identified happened to be leukemia. In 2020, again, even though out of the total new cancers identified, it was only 3.4%, out of the cancer deaths, it was 3.8%. And again, out of 1 lakh population, approximately 32 people were affected in 2017. AIDS standardized incidence rate, it is the highest in the East Asia region, where you have 10 people affected per 1 lakh population. Now coming to the predisposing conditions, you have the inherited predisposing conditions and acquired ones. The inherited predisposing conditions, trisomy 21 or Down syndrome, the Leaf-Romani syndrome, the Fanconi anemia, which is an autosomal recessive condition, Bloom's syndrome, and ataxia telangiectasia, where the patient could have all of these. Patient has a predisposition to develop leukemias. But thankfully, these syndromic conditions are not very common. And many of the leukemias you may be seeing in people who do not have any of these syndromes. So, the acquired conditions which could predispose the patient to develop leukemia would be myelodysplastic syndrome, radiation exposure, either for previous cancer or somebody who is working in a field where he or she is exposed to radiation, previous chemotherapy for some other cancer, Epstein-Barr viral infection, smoking, and exposure to benzene. So what is happening? Why do they develop these leukemias? So as I said, the myeloid and lymphoid progenitor cells undergo multiple genetic injuries. This is the main trigger that makes them transform into malignant cells. Okay, so you have multiple genetic injuries, and this causes them to transform into malignant cells. And with that malignant transformation, you have the immature hematopoietic cells proliferating and accumulating into the bone marrow and peripheral blood and other tissues. Other tissues, mainly the liver and the spleen. Okay, so when this happens, when the bone marrow is filled with these proliferating abnormal malignant transformed cells, it actually inhibits the normal hematopoiesis, and then once the inhibition of normal hematopoiesis happens, the patient starts having symptoms of acute leukemia. So what will be common clinical findings which actually should be red flags when you see a patient? So commonest would be pallor. In the presence of icterus, we can actually identify that probably this patient has a liver infiltration because of the leukemia. The lymphadenopathy could actually mean that the malignant cells have infiltrated the lymph nodes, and in the presence of edema, the presence of edema could actually mean that this patient has been having a prolonged anemia, which led to the edema, cardiac failure and edema. And also, another cause for this edema is the lymph node, which is enlarged and compressing the veins, which may thereby lead to edema. Okay, so both possibilities have to be thought of. Now coming to the vital parameters, the patient may be having a fever, tachycardia, tachypnea or stridor. Presence of stridor actually means that there may be a lymph node or a mass which may be impinging on the trachea and causing the stridor. Now when you look into the mouth, you may be seeing gum hypertrophy. Gum hypertrophy is usually associated in acute myelomonocytic leukemia or monocytic leukemia, AML M4 or M5. And there may be leukemic infiltration of the skin. The skin may, in certain areas, be erythematous, hard, firm to hard to feel. And there may be bleeds because of thrombocytopenia. And bony tenderness, when you touch the bone, because of the periosteal infiltration, because the cells, the blasts have actually infiltrated into the periosteal region. The patient may be having very severe pain and sometimes may not be able to bear weight. This happens to be a very common presentation for children with acute lymphoblastic leukemia, where some child who has been running around everywhere, and suddenly when this periosteal infiltration happens, because it happens only over a period of very few weeks, days to weeks. So a child who had been running around till yesterday, who was jumping from the windowsill down, from the chair down, now refuses to walk, now refuses to stand up from his sitting position and wants the parent to carry him. This particular symptom should not be ignored, and because this is the most common presentation, one of the most common presentations of acute lymphoblastic leukemia in a child. So somebody who may be telling you about such a history, please refer this child to a person who will be able to diagnose the disease and treat the disease. So, and pathological fractures could also cause bony tenderness in the patient. It may be in the ribs, it may be in any of the long bones, maybe in the vertebra, any bone can be affected for that matter. Now coming to the common clinical findings on systemic examination, the pulses may be deranged. You could have an arrhythmia because of the tumor lysis and the electrolyte imbalance. The BP may be low if the patient is in neutropenic sepsis. When he has a prolonged anemia and the JVP may be elevated. Listen to the heart sounds. Are they muffled? Could this patient be having a pericardial effusion also? Anything is possible. Hepatosplenomegaly, again, because of the infiltration of the blast into the liver and spleen. Just like pericardial effusion, the patient could develop a pleural effusion. They could be having wheeze or bronchial breathing secondary to lymph node in the bronchus. Presence of a partially obstructed bronchus will cause a wheeze, and a completely occluded bronchus, which leads to atelectasis and or consolidation because of the pooling of secretions, could cause a bronchial breathing. And it also could get infected after that because the immunity of the patient is compromised. So now, again, the CNS could also be affected. They could have a change in sensorium when they have a CNS leukemia, infiltration into the brain or into the meninges. Cranial nerve involvement. The patient could present with a facial nerve palsy, unable to, and it should not be missed and thought of as Bell's palsy. It could be an LMN facial palsy, UMN facial palsy, anything. Focal neurological deficits like paraplegia could also be a presentation of leukemia. So that was what I was trying to tell you at the beginning, that the presentation of leukemia could be so vague, so weird, that unless you look for it, you may not be able to find it. So how would you confirm the diagnosis? So confirmation of diagnosis of leukemia, So confirmation of diagnosis of leukemia would be by you definitely need the complete blood count with the peripheral smear in the beginning. And if the patient could be having a leukocytosis or a leukopenia, either could be present, or even having a normal count of WBCs. And the patient may or may not be having anemia. Thrombocytopenia also may or may not be there, evidently present. Now, when you look at the peripheral smear, presence of nucleated RBCs, the NRBC, presence of NRBC in the peripheral smear in any patient who has a vague presentation should alert you that the bone marrow, there is some strain coming to the bone marrow, and this person's bone marrow test has to be performed to confirm what is causing the strain on the bone marrow. It could be a leukemia, it could be something else, whatever. Nucleated RBCs are not normal in peripheral smear. Findings in the WBCs, it may be present, the blasts may or may not be present. Basophilia, presence of basophilia, less than 1% basophils in the differentials is normal in a peripheral smear, but more than 1%. One cell is acceptable, but more than 1% of basophil in the peripheral smear should alert you to evaluate further for this patient. And this patient could be having chronic myeloid leukemia or some other kind of bone marrow issue. So, basophils should alert us. Eosinophilia may be a presentation of lymphoblastic leukemia also. Now, coming to the platelets, mostly they present with thrombocytopenia, and thrombocytosis may be seen in some patients with myeloproliferative neoplasms. Coming to the peripheral smear, presence of 20% blast. Presence of 20% blast within the peripheral smear makes it clear that it is acute leukemia. Presence of 20% blast is showing that the person has acute leukemia. Okay. Again, now you need to do the bone marrow of this patient to find out what is the state of the bone marrow. As I said earlier, the abnormal cells will proliferate within the bone marrow, and the normal hematopoiesis gets suppressed. So, in the bone marrow, both the microscopy as well as the confirmation of the cell of origin should be done by flow cytometry. I'll come to the principles of flow cytometry in the next slides. So, microscopy, you are aware, the aspirate is stained with the Romanowski stain, and 20% blast. Again, in the peripheral blood as well as the bone marrow aspirate, presence of 20% blast indicates acute leukemia. Now, rarely the bone marrow aspirate could be a dry tap, because the bone marrow is actually filled with all those cells and they stick to each other, and you are not able to aspirate the cells out into when you try to aspirate the liquid marrow. So, in such a situation, when you have a dry tap of bone marrow, the biopsy will be the one that will be helping you to confirm the diagnosis, and the presence of round cell infiltrate. Presence of round cell infiltrate in the biopsy can be confirmed, the type of cell can be confirmed by immunohistochemistry, IHC. Immunohistochemistry will be able to identify which kind of cell this is, which is causing the round cell infiltrate. Okay, so with that, you rarely you may have to the diagnosis of leukemia may have to be done through the biopsy, but most of the time, either the peripheral blood will show 20% blast, or the bone marrow will be able to, the aspirate itself will be able to confirm the diagnosis of leukemia. Now, so here I've also mentioned about karyotyping and cytogenetics. So, why is it important? On one side, when karyotyping and cytogenetics will actually help you to identify mosaic down, which, as we discussed earlier, is a predisposing condition for developing Down syndrome, is a predisposing condition for developing leukemias. At the same time, there may be acquired mutations which are present within the blast, within the chromosomes of the blast, which you may be able to identify. Okay. So, we will go into the further details of this. So, what is it? Hypodiploidy, which actually means that the number of chromosomes will be less than 46%, 46 XX or XY, and hyperdiploidy when the number of chromosomes are more than 46 X or XY, either of these. Okay, so the hyperdiploidy and hypodiploidy. The hypodiploidy actually indicates a poor prognosis and poor response to the disease, chemotherapy to the disease, and hyperdiploidy is most of the time considered a good prognostic marker. So, you will be able to identify the prognosis to a certain extent from the karyotyping. And again, there are leukemias which actually have a recurrence genetic abnormalities which define the leukemia. So, in AML M3, the acute promyelocytic leukemia, you actually have the translocation in 1517. A trained eye, a person who has been looking at the cytogenetics consistently, will be able to pick up this translocation 1517 from the karyotyping. For others, like you and me, we'll have to use the FISH probes, the fluorescent in situ hybridization, using the probe to identify the 1517 translocation. So, either of the two, a trained person who will be able to identify, or FISH, either of the two will be able to identify the recurrent cytogenetic abnormalities. So, one of those is 1517, it is pathognomonic of AML M3. Then you have the 814 translocation, which will help you in diagnosing the Burkitt leukemia when you have when you actually have a confusion whether which type of acute lymphoblastic leukemia it is. Burkitt leukemia is conventionally considered in the FAB classification as ALL-L3, but it's treated differently because it behaves differently as compared to ALL-L2 and L1. Okay. Now, coming to the 922 translocation, if the peripheral smear shows all these different stages of the myeloid precursors, and it is suggestive of a chronic myeloid leukemia, presence of a 922 translocation will actually help you confirm that it is chronic myeloid leukemia. And if the peripheral smear shows acute lymphoblastic leukemia like BLAS, and then you have a 922 translocation, you can understand that it is a pH positive ALL. So karyotyping is also very important in the diagnosis of leukemias. Now, coming to the confirmation of the cell of origin. So, earlier I had told you, we had discussed regarding the flow cytometry. Now, flow cytometry has become a very important tool in diagnosis of leukemia, because when morphology could be confusing, when you are not able to confirm from the cytochemical stains, the MPO, the Sudan black, the periodic acid shift, none of these are able to actually pinpoint the type of cells from which the leukemic blasts have originated. The flow cytometry actually comes to the rescue, because the flow cytometry of either the bone marrow aspirate or the peripheral blood, whichever is containing blasts, it is actually subjected to an antibody conjugated fluorescent dye. This dye is applied into into a vacuole containing the specimen which contains a blast. It may be a bone marrow aspirate, it may be a peripheral blood. Now, these cells are run through the flow cytometer, where the cells move into, they are moved singly through a chamber, and laser is passed through this chamber, and it identifies and finding out which are the different kinds of cells within the specimen. Okay, so here the scatter which happens when the beam of laser falls on the cell, each individual cell, which will be captured on a screen, and this is called the flow cytometry plot. So the scatter will be captured on the screen, and from this you will be able to identify which is the type of the cell differentiation marker that is present in the cell, this particular patient's clone. So here I'll give you a small example. It is like when you look at this flow cytometry plot, it actually looks like a graph, which we have all studied during our maybe before 10th standard or before plus 2. So when you look at the graph, you have the x-axis and the y-axis. So and the point where the x-axis and the y-axis join together is like the 0 point. Okay. So here, as you move away from the 0 point, in the graph you have a positivity coming in. Yep. Okay. So here also it is the same thing. So when you have a blast which has a CD19 positivity, you expect it in the upper part of the plot. And when it is also CD10 positive, both together should be shown in this area. Okay. So here in this group of cells, you have the CD19 positivity as well as the CD10 positivity. So both these together, both these are markers of acute lymphoblastic leukemia. So these are B cell markers. And when you have these both together, coming together, you can identify that this patient actually could be having a B acute lymphoblastic leukemia. So that is how you interpret the flow cytometry plot. It is just for future. Anytime you may be having to see such a thing and somebody may be asking you to explain it to them. So this is how this works. So different markers are shown on the either sides, and the x-axis and the y-axis, and you have the scatter plot showing you which is the group of cells, the clonal group of cells, and these are the normal cells which do not show a clonality. Okay. So coming to the we've gone through the screen through the flow cytometry plot. Now coming to screening for complications. So now this particular patient you have identified as having leukemia based on the clonal proliferation of hematopoietic progenitors, and you've reached a diagnosis that this person has a leukemia. So now what are the other things that you should be looking for? Now you need to screen for complications like whether this person has a tumor lysis, because of which he could be having the dyslipidemia, the hyperkalemia, hypocalcemia, hyperphosphatemia. Any of these, hyperkalemia as well as hypocalcemia, could actually cause arrhythmia in the patient, and the sudden death could occur. And the hypocalcemia and the hyperphosphatemia actually could cause the hyperphosphatemia the phosphate crystals could deposit in the kidney and cause renal injury. Hyperuricemia could also contribute into the renal injury, and because of this you could have raised creatinine, and the increased proliferation within the bone marrow is seen in the LDH, increased high LDH. So you could have a hyperkalemia, hypocalcemia, hyperphosphatemia, hypocalcemia, not hypercalcemia, and hyperuricemia, and raised creatinine because of all this. Okay. So tumor lysis is one of the fatal complications of acute lymphoblastic leukemia, which if identified early and treated early could salvage the life of the patient. Now we had already discussed about the first patient. The case in the case scenarios was a person who had prolonged PT-INR, prolonged APTT, low fibrinogen, and low platelets, And we had not actually mentioned about the D-dimer and or the fibrin degradation products in that particular patient. But all these, the prolonged PTINR, prolonged APDT, low fibrinogen and low platelets with or without the D-dimer elevated could actually means that this patient is a DIC. Coming to the treatment of leukemia. So, treatment of leukemia is not chemotherapy alone. When the patient could have any number of complications like this, we've already mentioned about the different kinds of complications. So, it is not only in tackling the abnormal, malignant, proliferating cells that the treatment of leukemia lies, because unless you, by the time you finish trying to kill off all those abnormal cells, the person could actually be having a lot of other organ involvement which could lead to death of this patient. So, the patient has to be treated as a whole. So, for the supportive treatment, we need to look into the airway, breathing, circulation. If there is a stridor, the airway has to be secured, breathing has to be secured, the circulation. If there is a hypotension, we need to start this patient on inotropes. So, the hypotension may be because of a neutropenic sepsis, the patient has to be started on antibiotics for tackling the neutropenic sepsis. If the patient is in tumor lysis, the adequate hydration is necessary to maintain the renal function, to reduce the renal injury. Uric acid reducing agents have to be given to the patient. Electrolyte correction has to be done to prevent arrhythmias. And if he has anemia, the PRVC transfusion has to be given. If he has a thrombocytopenia, he requires a platelet transfusion to prevent bleed, antibiotics for coexisting infections, and certain patients, especially those with acute lymphoblastic leukemia with severe neutropenia or acute myeloid leukemia where the myeloid series are abnormal and normal cells have been replaced by the abnormal malignant cells. Both these groups, acute leukemias, the patients would be having very low neutrophil, normal functioning neutrophils, which will predispose them to develop fungal infections, especially in our state. In our state, probably because of the humidity and the warmth in the condition, we already, most of the time, we have been experiencing fungal infections much more common than it is seen in the West. Probably the climate explains it. Because in the West you have a cooler climate which is much more dry, and here we have a very humid climate which is very warm, and it actually helps the fungus to flourish. And neutropenic patient is a very good, the medium for the patient, for the fungus to proliferate. Now coming to the definitive treatment, once you have tackled all the supportive treatment, all the organs are functioning well, then you start the definitive treatment for this patient. It will be chemotherapy based on international treatment guidelines. The international treatment guidelines keep getting updated each year because there is so much research happening in trying to improve the outcome of each of these cancer patients, each of these leukemic patients. So, whatever has been used some 10 years back may not be relevant now, may not be relevant at all now because it keeps changing. There is so much research happening. The whole world is trying to reduce the toxicity as well as increase the survival and improve the outcome of the patient. So, chemotherapy as per international treatment guidelines. And acute lymphoblastic leukemia, the treatment will also involve, along with the chemotherapy, corticosteroids. This will be mentioned in the international treatment guidelines, but corticosteroids are not regularly used in acute myeloid leukemia treatment. Now, if you are able to identify the type of cells from, as I mentioned in the flow cytometry, we'll be able to identify the cell differentiation markers. And if you have a targeted molecule which will hit the particular cell based on its cell differentiation marker, suppose you have a patient who has a clonal proliferation of cells which actually have a CD20 positivity. Rituximab is a very good drug which will actually target those cells, and you could get the clonal cells out. So, rituximab alone may not be enough in a malignant proliferation, but it will help in bringing this patient into remission. Now, you may have heard about autologous transplantation, allogeneic stem cell transplantation. So, what are these? So, the role of these transplantation, the stem cell transplantation, actually comes in the consolidation therapy in relapsed or high-risk disease in leukemias. Okay. So, now what is the procedure? So, you need the patient should be, the patient, or rather you call them the recipient. The recipient should receive high-dose chemotherapy or with or without radiation to ablate the whole bone marrow which is there. And because once the bone marrow is ablated, they will not be able to have normal counts. They become aplastic. You replace them with healthy stem cells from a donor. Okay. So, the recipient's cells are ablated with chemotherapy or radiation. Sometimes radiation alone along with small dose chemotherapy, and sometimes both the high dose chemotherapy as well as small amount of radiation would be required to ablate the bone marrow. So, the conditioning regimens differ based on the condition of the clinical condition of the patient. Now, the sources of stem cells. If the stem cells have been harvested from the patient itself, it is called autologous stem cell transplantation, and if it is from a different individual, it will be called the allogenic stem cell transplantation. Now, we need to be aware about a few terminologies which are commonly used in leukemia. One is induction. Induction means the initial treatment of leukemia. It is usually with chemotherapy. The initial treatment of leukemia, and the induction is one of the most important things, the treatment part, which actually, if successful, the patient goes into remission. So, remission is a disease-free state which happens after the treatment. So, you have the induction when you start the treatment for the leukemia. The remission is the state which the patient achieves if he responds to the treatment and he becomes disease-free. If he does not respond to the treatment, it is called refractory disease. And if after initial response, when you do the reassessment bone marrow, it doesn't show any blast or leukemic cells, and it means that normal bone marrow cells have come back. And then, if the abnormal malignant clone comes back maybe after a few weeks or months or years, it is called relapse. So, these are the few of the common terminologies that you should be aware: the induction, remission, refractory disease, and the relapse. Now, another terminology used commonly in leukemia treatment would be consolidation. Consolidation, I mentioned about consolidation during the autologous and allogenic stem cell transplantation. The consolidation is the treatment given to patients who have achieved remission, and it is intended to prevent relapse. So, consolidation is not the treatment which you give to a patient who has an active disease. Somebody who has an active disease receives induction, a new disease receives the induction, and somebody who has achieved remission. To prevent relapse, they receive consolidation therapy. So, consolidation therapy could be high-dose chemotherapy alone, or autologous transplant in high-risk disease where they are at high risk of developing relapse. And allogenic stem cell transplantation is done in those patients who have a matched donor within the family or outside. So, coming to the next terminology which you need to be aware about, it is the continuation treatment or maintenance, where in consolidation you actually talk about high-dose chemotherapy. In maintenance or continuation therapy, the patient receives very low-dose chemotherapy for a prolonged period, usually lasting for 1 to 2 years. And this is also intended to prevent relapse. Incorporating the maintenance or continuation therapy into the treatment of acute lymphoblastic leukemia has actually reduced the relapse rates, and the survival has improved a lot over the years. Now, we should also be aware about a few newer treatment modalities which have been found useful in patients who have been refractory to conventional chemotherapy and who have probably relapsed even after allogeneic stem cell transplantation. So these patients will be are currently the ones, the high risk patients are the ones who undergo CAR T cell therapy. So what is this CAR T cell therapy? So you just need to be aware about the terminology. So it is a chimeric antigen receptor. So this normally what happens is any of our cells, if we develop these mutations which will cause them to have a malignant proliferation, our own immune system, the T cells, will identify that cell which has a tendency to become malignant, start proliferating, and this particular cell gets taken off from the system by the T cells. It will phagocytose the abnormal cell and it will not be allowed to proliferate. But in a patient who has leukemia, this particular security system of this T cell phagocytosing the abnormal cell has been failed. Okay, so that system does not function for them normally. So you teach the T cells by using a chimeric antigen receptor that this, if you find this particular cell differentiation marker on the cell, when the cell encounters another cell, so here what do? They isolate and activate the T cells. The T cells are taken out from the patient's body. It is activated. Then the chimeric antigen receptor is incorporated into it. These cells are made to proliferate, and the same cells are transfused back into the patient. So these chimeric antigen T cells, which come back into the patient's body, they start to attack all those cells which have the antigen, which these T cells will have the receptor. Am I clear? So you incorporate the receptor into the T cells, and this receptor will identify the antigen on top of the cell, the malignant cell, and the T cell will be able to identify that this is not normal, and the T cell will be able to phagocytose it. Okay. So currently this is a newer treatment, and it has been world over with research. They have been able to do it successfully in only a few B cell leukemias. The research is still going on, trying to find out whether it will be possible to do it in other leukemias. Again, this is also an antibody which on one side has a molecule which will link it to the CD19 cell on the blast, and on the other side it will help the T cell of the patient by binding to the CD3 molecule on the T cells. And once this bond happens, the blinatumomab will bind the CD19 cell and the CD3 cell. Once this happens, the T cell will be able to phagocytose the CD19 cells, which the cell was not able to identify previously. Okay, so this is also the newer treatment modality. It is a little complicated, I know, but then you need to be aware about the terminology. The BiTE antibody, which has a CD19 and CD3 moiety, which will bind the T cell and the B cell, and this is also for refractory B cell leukemias. Now, the 5-year overall survival. The best is for acute lymphoblastic leukemia in childhood. Less than 20 years, they have found close to 89% survival over 5 years, and most of them get cured. 18 to 45 years, this comes down drastically to 50 to 65%, and 46 to 65 years, it comes down again further to 25 to 46%. And beyond 65 years, if somebody has an acute lymphoblastic leukemia, the 5-year survival is expected to be close to 7 to 11%, somewhere around 10%. The results are similar for CLL and CML. For a childhood acute lymphoblastic leukemia, both of them have, the CML and CLL has a 5-year survival of more than 80%. And acute myeloid leukemia is one of the most difficult ones to treat. In children, the treatment outcomes has improved to maybe 60 to 70%. In adults, it remains at below 50%, it is close to 29% world over. Now we come back to the initial case scenarios. So how do we treat this particular patient? We had seen this patient who was a 35-year-old man who presented with gum bleeding, and he did not have any organomegaly. His cells had showed pancytopenia, and he had features of DIC. So we had thought of, and in the peripheral smear, we had seen the OR rods in this patient. He had the granules in the cytoplasm of the blast. The blasts were large, almost 7 times the size of the RBC. And so we reached a possible diagnosis of acute myeloid leukemia, AML-M3, acute promyelocytic leukemia. So again, the confirmation is by flow cytometry, and FISH for translocation 1517 will clinch the diagnosis that it is acute myeloid leukemia M3, AML-M3, or acute promyelocytic leukemia. Now, how do you treat this AML-M3? So why did I particularly place this case scenario was, this is the only condition where without chemotherapy, this patient could actually come out of the disease. You need to identify this earlier, only when you have a conviction that this is possibly something abnormal, that this patient will reach the person who is able to treat this patient, and that means you refer this patient to somebody who is able to treat this patient. Okay, so once a diagnosis is reached, the treatment has to be started at the earliest, because this patient is already in DIC. He could bleed to death within 2 days. So first, you need to have a suspicion that this patient could be having an acute myeloid leukemia, AML-M3 especially. And once you confirm the diagnosis by FISH for translocation 1517, you start the patient on all trans retinoic acid, which is vitamin A. Not the regular vitamin A, you have an ATRA or all trans retinoic acid, ATRA. Okay, so you have the ATRA or the all trans retinoic acid and arsenic trioxide, which is ATO. So both these together will help in differentiation of the promyelocyte, which will be able to differentiate into a mature neutrophil. And that is what happens in the promyelocytic leukemia. You actually have the myeloid precursors getting stuck at the level of promyelocytes, and they are not able to differentiate further into the neutrophil stage. So when you give them ATRA plus or minus all trans retinoic acid, they actually start differentiating and form the mature neutrophils, and the patient gets cured. Now, supportive transfusion of blood products, one is to control the bleed, you'll have to give platelet transfusions. If the patient is having anemia, you need to give blood PRBC. For control of the DIC, the patient will require cryoprecipitate, fresh frozen plasma. Okay, so that the patient's life can be saved. Now, coming to the next case scenario. Now, here you had a 75-year-old man who had been asymptomatic, and I incidentally detected to have leukocytosis with lymphocytic predominance. You had seen this patient having smudge cells within the peripheral smear, and after flow cytometry of the peripheral blood, you have reached a diagnosis of chronic lymphocytic leukemia. Now, this particular patient, when you look at his hemoglobin, it is normal, platelets are normal, no lymphadenopathy, no clinical hepatosplenomegaly. So what? There is no indication to treat. This patient can go home, come back maybe 3 months later, 6 months later, keep checking the counts, keep examining this patient every 6 months at least if he does not have any new symptoms, and look for lymphadenopathy, new onset hepatosplenomegaly. As long as nothing of that sort is there, if he continues, if it's only the WBC counts that is deranged and every other cell parameters and there is no lymphadenopathy, no organomegaly, this patient doesn't require any treatment. So that also we need to be aware. Who should be treated? So this gentleman doesn't need treatment, he just needs monitoring. Now the third case scenario, now you had a patient who was coming with cough, a 30-year-old man who had dry persistent cough, and in his X-ray we had seen the mediastinal enlargement. When you look at the normal person's X-ray, there is no such mass on that. I just kept an X-ray for comparison so that you will be able to appreciate the difference. Okay. So this particular patient had a blast. The blast in the peripheral smear was suggestive of T cell. And now again it will be confirmed with the flow cytometry. Flow cytometry showing clonal proliferation of cells which have the cell differentiation markers consistent with T cells, and he was identified to have a T cell acute lymphoblastic leukemia. Now, why was this patient having cough? The mediastinal mass could impinge on the trachea and irritate the trachea, which will cause a dry cough. So when you start treatment, you should also be aware that this patient could develop a sudden bleed into that mediastinal mass, which could actually compress the trachea and occlude the breathing. So this patient has to be monitored within the hospital while the treatment is initiated. And the airway, breathing, saturation all has to be monitored. He could go into acute hemolysis when you start the treatment, and with the virtue of which he could also develop a renal failure. And so that for preventing that, the patient should be receiving adequate hydration. Now, definitive treatment, steroids followed by chemotherapy. So steroids initially will help if the patient is responsive to the treatment, the mediastinal mass will shrink. And after this happens, once the WBC counts, if they are high, if they start coming, once they start coming down, the steroids will be followed by chemotherapy. I think we haven't mentioned the WBC counts in this particular patient because there were so many clinical findings which actually pointed towards the leukemia. Now, the fourth case scenario, it is about a football player who presented with not able to eat like before, and clinically it sounded like a splenomegaly because of the mechanical impingement on the stomach. And you have been able to confirm it by the clinical examination that he has a massive firm splenomegaly, and along with that he is also having pallor. The WBC count is 1,20,000 with predominant neutrophils. There are 2% basophils also seen in the CBC. You have all the myeloid precursors in the smear seen. So here you have the myeloblast, the promyelocyte with the granules, the myelocyte, again the metamyelocyte where you have the cells which the nucleus regressing and the cytoplasm increasing, the band cell, there is a band cell, yeah, okay, so this is a band cell, and the segmented cells or the mature neutrophils where you have lobulated nucleus. So you have all the different kinds of cells, myeloid precursors shown in the peripheral smear. Now coming to so this patient's diagnosis confirmed as a chronic myeloid leukemia by the microscopy. You need to confirm it by the FISH for translocation 922. And after this confirmation is made, the bone marrow study with flow cytometry to find the phase, confirm the phase of the disease. It could be chronic phase, accelerated phase, or blastic transformation phase. And once you have confirmed that it is only in the chronic phase, the treatment with tyrosine kinase inhibitors. It is a targeted molecule which targets the 922 translocation, which in turn will help in making the patient go into remission. Okay. So this particular group of drugs, the tyrosine kinase inhibitors, the first tyrosine kinase inhibitor, imatinib, was invented probably in the early, it became marketed for, in the early 2000, early 2000, and after that, actually over the last 20 years, the survival of the chronic myeloid leukemia patients has improved a lot. We'll be going into the multiple choice questions pertaining to leukemia. So the first one, which of the following medications should not be given intrathecally? Methotrexate, cytosinicline, vincristine, hydrocortisone. So the answer to this particular question is vincristine, because all the other 3 drugs have been found to be safe to be given intrathecally, and if vincristine, even by mistake, happens to be given intrathecally, the patient could develop a rapid ascending encephalomyelitis, and it could be a fatal condition for this patient. So vincristine is one drug which should not be given intrathecally. MCQ number 2. Now we have a patient who has acute leukemia, who is admitted with febrile neutropenia. On day 4 of being treated with broad spectrum antibiotics, his fever increases. He is on broad spectrum antibiotics for the last 4 days and his fever increases. CT chest shows, CT chest with high resolution cuts shows tree in bud appearance. Which of the following is the most appropriate step in the treatment to be taken? So options: add antiviral therapy. Option B, add antifungal therapy. Option C, add cotrimoxazole. And option D, continue chemotherapy. So when you have such a question, you need to be thinking about what might be the condition that this patient could be having. So adding antiviral therapy for a patient with neutropenia, maybe it may be required because the patient could be having a CMV. But here you have a clear-cut evidence that this patient has a CT chest with HR cut showing the tree in bud appearance, and this patient already has been on broad spectrum antibiotics, which makes him prone to develop fungal infection. So adding antifungal therapy is the most appropriate step here. So why not add cotrimoxazole? Okay, so adding cotrimoxazole to the treatment in a patient who has febrile neutropenia, cotrimoxazole has a myelosuppressive effect. So the recovery of the bone marrow, the recovery of the neutrophils will get delayed when you add cotrimoxazole to the treatment. So adding antifungal is the most appropriate measure to be taken, because development of a fungal infection, especially something like an aspergillus infection in the lung, is the most common thing that happens to a patient who has a prolonged febrile neutropenia. Now, coming to the MCQ, number 3, which of the following medications would not be useful in a patient with acute myeloid leukemia and hyperleukocytosis? Hyperleukocytosis means the WBC count is more than 50,000, more than 1 lakh, and the counts are in lakhs. So which among these medications are not useful in hyperleukocytosis? So the first option is hydroxyurea, second option is rasburicase, third option is low dose cytarabine, and fourth option is cyclosporin. Of these, cyclosporin is a immunosuppressive drug. It acts against, it's a calcineurin inhibitor which acts on the blocking the T cell receptors, the T cell lymphocytes. So T cell lymphocytes are extremely important for us to control the leukemia. So anyway, it is not cyclosporin that has to be used. Hydroxyurea, again, hydroxyurea is a myelosuppressive agent. So it will be useful in a patient who has hyperleukocytosis. What is rasburicase? Rasburicase is the enzyme which actually cleaves the uric acid, and anybody who is having hyperleukocytosis, when you start treatment for this patient, the cell will be destroyed, and all that nucleic acid material which comes, which gets out of the cell will actually get digested by the xanthine oxidase and form the uric acid as an end product. So rasburicase will cleave already formed uric acid and help in preventing the renal failure in the patient. Low dose cytarabine, again, because it's not a high dose chemotherapy, it will help in myelosuppression. What will happen if you give high dose chemotherapy to a patient who has a hyperleukocytosis? The sudden destruction of all cells, the patient will go into massive tumor lysis and he could develop renal failure and die. So hyperleukocytosis has to be tackled carefully, and the patient's counts need to reach a near normal state before you are able to start him on high dose chemotherapy in most conditions. Now coming to MCQ number 4, in hairy cell leukemia, the hairy projections are seen over option A, myeloid cells, option B, macrophages, option C, B cells, and option D, T cells. So hairy cell leukemia, even though the terminology is leukemia, it is actually a low-grade lymphoma which develops from the B cells. So the circulating B cells will have the hairy cells projections. Now coming to the MCQ number 5, which of the following types of leukemias is administered prophylactic methotrexate for CNS prophylaxis? So option number A is acute myeloid leukemia, option B is acute lymphoblastic leukemia, option C is chronic lymphocytic leukemia, option D is chronic myeloid leukemia. Prophylactic methotrexate. Methotrexate is one drug which acts against the lymphoid blasts. So lymphoid blasts are naturally seen in the acute lymphoblastic leukemia. So prophylactic methotrexate will be for CNS prophylaxis will also be used only in acute lymphoblastic leukemia. Now, the chromosomal abnormality seen in acute promyelocytic leukemia. I think we have already dealt with it in the leukemia presentation. So I hope there wouldn't be any more confusions. It is translocation 1517. Coming to the MCQ number 7, which of the following combinations of cytogenetic abnormality associated leukemia or lymphoma is incorrect? So translocation 814, Burkitt lymphoma, yes, it is associated with Burkitt lymphoma. Translocation 1517 associated with AML-M3, yes. Translocation 1418 with CML. So what is the translocation, the mutation seen in CML? It is translocation 922. So 1418 is unlikely. Let us look at the last one. Translocation 922 in ALL. Yes, Ph positive ALL is possible. So 1418 unlikely. All the others match. So it is 1418. 1418 is actually seen in follicular lymphomas. Coming to the last MCQ, which of the following is not compatible with chronic myelomonocytic leukemia? CMML. Peripheral blood monocytosis of 1 into 10 raised to 9 cells per liter, absence of Philadelphia chromosome, less than 20% blast in blood or bone marrow, absence of minimal dysplasia in the myeloid lineages. So when you have, when the diagnostic criteria for chronic myelomonocytic leukemia includes peripheral blood monocytosis, includes absence of Philadelphia chromosome, less than 20% blast or bone marrow is also required to confirm, call it chronic myelomonocytic leukemia. But the dysplasia in the myeloid lineage is required. It is a required criteria. It is more than 10% dysplasia in one or more cell lineages is essential for chronic myelomonocytic leukemia. So this is the option which does not match. So with that, we come to the end of this leukemia class. I hope it has been useful to you, and I hope this will make you more interested in the field of either clinical hematology or hematopathology, and at least a few of you will be able to pursue this beautiful subject for your future career.
Docemy.